Hello, my name is Nari Beatty, and today I will be presenting my responses to the Unit 4 case connection scenarios. So for this Unit 4 case connection, I decided to do cases 3 and 4. So starting off with case 3, we have a patient that is diagnosed with gout. And regarding the first question to this case, it states, explain why the other choices are not consistent with the data or results displayed, and what additional information you may need to decide the root cause of his diagnosis of gout. So the choices presented were 1, overproduction of purines, 2, decreased salvage of purines, 3, decreased urinary excretion of uric acid. So for this first question, the presentation of gout in this individual, according to his lab results of high plasma urate and low urinary uric acid levels, could be due to underexcretion of urinary uric acid, as his plasma uric acid levels are above normal. So they were displayed as 10.5 milligrams per 100 milliliters when they're typically supposed to be less than 7 milligrams per 100 milliliters, which is the normal range. Gout develops through increased uric acid concentrations in the blood, also known as hyperuricemia, and that results in either overproduction or, in this patient's case, underexcretion of uric acid. As this patient has an overproduction of plasma, it could be possible for him to have excretory deformities, resulting in dysregulation of the kidney and how it metabolizes urate. Also, increased amounts of PRPP, also known as phosphoribosyl pyrophosphate, increase purine production, leading to the patient's higher content of uric acid in the blood. So the high levels of urate in his plasma contribute to the inability to eliminate urinary uric acid. Overproduction of purines wouldn't be consistent with his lab results, as it would typically develop an increase in urinary uric acid, as his lab results show otherwise. Regarding purine salvage, decreasing it would result in higher levels of uric acid, whereas increasing purine salvage would decrease levels of uric acid, which is shown in the patient's case. Therefore, decreasing salvage of purines would not be a reasonable option either. So moving on to the second and last question for this case, it stated that the patient tells you that he switched from diet to regular soda because he read that the fake sugar diet soda was bad for him. So what is the potential impact of this dietary modification on the presentation of this patient's diagnosis of gout? So the potential impact of consuming higher levels of fructose or high fructose corn syrup levels could lead to more serious and painful symptoms of gout. When fructose is further broken down within the body as it's taken up by the liver, the production of purines is present, which eventually leads to increased uric acid production. The uric acid has been shown to cause painful small crystals within the joints, causing them to swell. This can most likely explain the severe pain that this patient was experiencing in his big toe. So moving on to case 4, we have a patient that is dealing with megaloblastic anemia and apparently has a vitamin deficiency. So regarding the first question, it says, which of the following vitamin deficiencies listed is the probable cause of this patient's presentation, and discuss each option. So the list of vitamin deficiencies were iron, B6, and B12. Iron deficiency occurs when an individual either doesn't consume enough dietary iron from their diet, has a defect in iron absorption from possibly Crohn's or ulcerative colitis, from either chronic blood loss from menstrual cycles or consistent internal bleeding. Vitamin B12 deficiency is mainly due to the lack of healthy red blood cell production, resulting in oval, large-sized red blood cells, which is also known as megaloblastic anemia. This can be caused by, or this could be due to the lack of intrinsic factor, which is produced by the stomach to properly absorb vitamin B12, or this could be due to other autoimmune diseases. Vitamin B6 deficiency occurs when there are other vitamin deficiencies, such as B12 and folic acid, as well as excessive loss of healthy red blood cells and malabsorption. So the symptoms of vitamin B12 result in red blood cells decreasing in size, and this is also known as microcytic anemia. Also, it could lead to dermatitis cheilosis, which is the cracking of lips or areas around the mouth, and or swelling of the tongue, which is glossitis. This patient did show signs of beefy, which is most likely an inflamed tongue, and it was also red with loss of papillae, and she had pale conjunctiva, which is also a sign of vitamin B12 deficiency. So she didn't show any signs of bloody stool, but she did complain about having mild diarrhea, which is also a sign of iron deficiency. So regarding the second question of this case, it said discuss how this vitamin deficiency impairs purine or pyrimidine metabolism. So now that I've confirmed that this is possibly a vitamin B12 deficiency, during pyrimidine nucleotide synthesis, orotate phosphoribosyltransferase transferase makes a nucleotide of aridine monophosphate and is then decarboxylated to uridine monophosphate by orotitylate decarboxylase. Then the phosphoribosyltransferase transferase and decarboxylase activities occur through catalytic domains through UMP synthase, which is known as a polypeptide. Vitamin B12 can impair pyrimidine metabolism as a condition called orotic aciduria is caused by either a defect in phosphoribosyltransferase transferase and or decarboxylase activities, and could result in orotic acid deposits in the urine. So for the last question of this case, this is pertaining to a list of potential laboratory tests and findings that would assist in your differential. So in my case, choosing how B12 deficiency is proving the case of her megaloblastic anemia. So some laboratory tests and findings that would assist in showing that this patient's symptoms are due to vitamin B12 deficiency would be a methylmalonic acid test. And so these methylmalonic acid, first off, is made during metabolism, and if the body is lacking this acid, or if it's lacking adequate amounts of vitamin B12, then that will result in extra amounts of methylmalonic acid. So another test that could be used is a homocysteine test. And homocysteine is an amino acid. It's an important amino acid that vitamin B12 breaks down to generate body's necessary chemicals. And so in this case, if homocysteine levels are elevated, that results in a lack of vitamin B12. And so this is the end of my responses for the Unit 4 case connections. And again, I chose to do cases 3 and 4 for this assignment. Thank you.